Okay. Good morning, everyone. I need to stand in this spot because we're live streaming this, and if I move, I go off camera. Very big welcome. Thank you for coming this morning. Thank you to those that are watching. We are going to be putting this onto YouTube properly so people can see afterwards. We think this is a great moment. It will be a first time for England to have in a single place, if you like, an index document that people can use right across the health service and government, local government, universities and industry, third and voluntary sector. Anyone can go to this document and to find the data that tells you as much as exists about our knowledge about the health of the people of England. It's not that this data is original, but it is the first time that it's brought together in a single place. And all of the factors as we have them that affect the health of the people. The most important message is that we are a healthy nation. And when we look at the health of the people of England relative to the rest of the world, there are very many reasons to feel very positive. And we've got lots to be proud of. In cardiovascular disease, we've seen a huge improvement in the last 10 and 20 years. In teenage pregnancy, infectious disease, which is a really important part of what Public Health England is responsible for, we've seen massive improvement over many, many decades. There's another truth, which is the healthy life that people enjoy in this country is not enjoyed fairly across all of society. And what our report today shows in very graphic detail is your life chances are very much determined by where you live and the circumstances in which you live. And much as we've been very proud of where we've made these great improvements and strides over the last number of years in tobacco control, in many, many aspects of the things that we know make a difference, what we really want to make the next big achievement is about how we address the unfairnesses in the life chances that people have. We know more, I think, it's more in the public conscience that there are differences in life expectancy dependent on where you live and your circumstances. Typically that's between 7 and 9 years, depending whether you're a man or a woman. Less clear, I think, in people's conscience is that you can double that number for life in poor health. So that's people living but in poor health. And although we have seen very, very big improvements in life expectancy, we haven't seen those improvements in healthy life. And in very layman's terms, so my terms and the public's understand, is people are just living longer. They're living longer, but in many cases in poor health. And that's something we can do something about. This is not something that just happens. This is something we can do something about. What we're hoping for, it is already beginning, but we think we need to just make it a bigger, stronger message, is that this is about all of government. As much as we will be concerned for getting smoking prevalence down, helping people about what's in the diet, what we're doing on taking sugar out of food, and getting advice to the people about drinking and the importance of exercise. More importantly still is the importance of people getting into work, having a reason for getting up in the morning, something meaningful to do, enough money to live on. And friendship, companionship, contact, people to care for and about, being connected in your life. So we will be saying to you in the course of this morning that economic circumstances really matter. Getting prosperity into people's pockets really matters. Getting jobs into parts of the country that haven't enjoyed the prosperity of London and the South East really matters. Having a job is good for your health. Being in work is a health outcome. And if you are in work and you become unwell, that we do better than we've ever done before in helping people to get back into work. And what you'll see this morning is that musculoskeletal, basically joint pain, and depression and all forms of depression, struggling at work, debt problems, struggling with relationships generally, those two things, depression and musculoskeletal pain, account for almost half of all of the reasons that people take sick leave from work. Again, these are things we can do something about. So it's a combination of using the data to help us understand where we can make the biggest difference, and the importance of economic prosperity being enjoyed by local people and shared more fairly across the country, mostly expressed through having a job, but also a home where you've got a roof over your head and being connected and joined in with society. So we hope that this data will be, what we're reporting today, what we're sharing with you today, will be a further stimulus for health being understood to be much more than about healthcare alone, much more than about the treatment of disease, but how we can prevent it, how we can help people enjoy more years in good life. We want people to live for as long as is possible. Absolutely, I've got to get this right, because I get this. I want people to live, right? Definitely. But even more than that, to live for as long as is possible in good health. And the difference in people's chances of that are just so great today that we need to be more bothered about it, and we need to be more active in changing that. So we're going to share with you masses of data. This morning is just to get it out there. What we want is then to answer as many questions as we can for you this morning, and then to continue the dialogue in the weeks and months to come. Thank you for this. I'm going to pass you over to Professor John Newton, who's going to present the highlights, and then both John and I will take questions. Thank you.
Okay, thank you very much, Duncan. I'm John Newton. I'm the Director of Health Improvement at Public Health England. As you can see, there is a great deal of data and information in these two reports. I'm just going to go through some of the highlights and draw out some of the big themes, some of which Duncan's already mentioned. As he's also said, I think it is fair to say that there's nothing completely new in these two reports, but we would argue that although they are out there, they're not well enough known, the results are not well enough known, and also not well enough used. And certainly, we don't believe that they are drawn together in such a broad way and to be found easily accessible anywhere else. So to start with our first slide, the first chapter covers life expectancy and the number of years that people live in good health, so-called healthy life expectancy. Provisional data for 2016 show that life expectancy at birth has now reached 79.5 for males, years for males, and 83.1 years for females. The chart shows trends in life expectancy and healthy life expectancy for males and females over a 12-year period. You can see that life expectancy for both men and women has increased substantially over that period, but so has healthy life expectancy. However, life expectancy has increased more than healthy life expectancy. However, it's in proportion. So although we are spending, both men and women are spending more years in poor health, we're also spending more years in good health. Women still live longer than men, but the gap has closed over time to just 3.6 years. However, most of the extra time that women have over men in terms of life expectancy is taken up by years spent in poor health. If we turn to the causes of death, on the next slide, we can see, again, some very substantial changes over this same period. The chart shows trends in age-standardized death rates for the leading causes of death for men and women. And we can see that death rates from heart disease and stroke have halved for both males and females, which is a very considerable achievement. But at the same time, dementia and Alzheimer's disease death rates have increased by 60% in males and have doubled in females. This partly reflects the fact that the population is aging and that now more than 2/3 of deaths are occurring in people over the age of 75, which is a profound change in patterns of mortality, which has a number of implications which we could discuss. But it's also important to understand that there's been an increased awareness of dementia and a tendency to code deaths as dementia. But nevertheless, the increase in the importance of dementia as a cause of death is profound for both men and women. Heart disease, however, remains the most common cause of death for men, accounting for almost twice as many deaths as the next leading cause, which is dementia and Alzheimer's disease. For females, dementia and Alzheimer's disease is the most common cause of death, followed by heart disease. It's worth pointing out that on this chart, individual cancers are presented, but if you take cancers together, they account for 30% of deaths for men and 24.8% of deaths for women, and that's in 2015. And there are 4 cancers in the leading 10 causes of death for both men and women. For both sexes, those include lung cancer, colorectal cancer, and leukemia and lymphomas. And for men, prostate cancer, and for women, breast cancer are also in the top 10 causes of death. Thinking about the causes of those causes of death, the trends are influenced by a broad range of factors. We refer quite a lot in the report to the Global Burden of Disease study, and there's a very nice piece of epidemiology in that study which looks at the population attributable risk factors, in other words, the proportions of these deaths which are due to individual risk factors, whether they're behavioural, metabolic or environmental. And we find that the leading causes of risk for deaths are poor diet and smoking, although other factors such as air quality and alcohol also feature. If we move then to look at causes of ill health, as mortality rates improve, of course, the causes and the experience of ill health becomes more important. And I think it's fair to say that epidemiology has focused more on mortality in the past and needs to move its focus to collecting good data and presenting good information about the causes of ill health as well as just causes of mortality. But that is more challenging, and we find it more difficult to find good quality data on ill health compared to mortality. Nevertheless, there is a good deal of data about. The chart here shows changes in age-specific morbidity rates, again taken from the Global Burden of Disease study. So these are years lived in disability per 100,000, and looking at each individual age group. If you take levels of ill health overall, there have been some improvements at age-specific rates, but of course the total burden of ill health has increased considerably over the periods from, say, 1990 to 2013. However, this increase is more than accounted for by the increase in the numbers of people and in the changes in the age distribution. In other words, there are more of us and we are getting older. However, the changes in ill health have not been as great as the changes in mortality. So if we look at this slide, we can see that there are in fact improvements in levels of ill health at almost all of the individual age groups, which has to be a cause for optimism, so that although people are living longer, we are healthier at any given age now than we were in the past. And that's the change that we need to drive further in the future if we are to address the changing structure of our population. Of course, the other message that comes out of this slide is the exponential increase in levels of ill health at different ages. So that, for example, people aged over 80 have twice the levels of ill health compared to people aged 60 to 64, who in turn have twice the levels of ill health as people in the 20 to 24 age group. So the fact that we now have 3 times as many people who are over the age of 90 as we had in the 1980s is a profound change in the likely levels of ill health in the population. Looking then again at the causes of ill health, Duncan referred to this a little bit earlier on, we find that at different ages, so we're presenting here three broad age groups in the adult age range, we can find that for, and this first slide is for females, I have the slide for males next, we find that musculoskeletal diseases, mental health diseases dominate, certainly if we take all ages together. And low back pain and neck pain are the predominant cause of measures of ill health. That's partly, of course, because they are extremely common. And of course, this is when one looks at the data for the whole population, the causes that dominate are the causes that are very common in the population. It's also worth mentioning skin diseases, which appear in the third rank when you look at all ages together for women. Also, if we look at the causes of ill health in the 70-plus age group, we can see a number of causes here, which of course are a very powerful set of causes which make older people less independent. So we have back pain and falls, which reduce people's mobility. We have sense organ diseases, which lead people to be isolated and less well able to look after themselves. And we have Alzheimer's disease and dementia, which causes disorientation and confusion. So we have a toxic cocktail of causes of loss of independence in older people. And I think those are the things which our services, both health and social care services, are experiencing. And the data explain this in some very, very starkly. Turning then to men, we have a similar picture, except that sense organ diseases are more prominent, and we're starting to see diabetes become a more important cause of ill health. In terms of the causes of ill health, compared to, as I talked about, the population attributable risks for mortality, the same data are presented in our report for ill health, and there's a slightly different picture. But smoking and alcohol use are very significant contributors. The leading causes, though, are high body mass index and high blood sugar. So there's a slightly different pattern of risks contributing to ill health compared to mortality, although there's a lot of commonality between the two lists. Moving on then to compare England with other countries, we have a chart here showing back to mortality, years of life lost, in terms of comparisons with the 28 EC countries, with men on the left and women on the right. And we're looking here at years of life lost, so this puts greater emphasis on deaths in early years compared to deaths in later life. And we can see that among the 28 EU countries, England was ranked 7th for males, but only 17th for females. For cancer, heart disease and stroke, men in England were doing better than the EU average. And for women, England was doing better than the EU average for heart disease and stroke, but worse for cancers. And that really accounts for the lower position for England for women in the European comparisons. For men and for women, respiratory diseases are worse in England than they are in other European countries. And it's worth looking at the individual countries concerned, because if we're thinking of the male mortality on the left, some countries like Sweden and Luxembourg are very small, so we really are ranking very high compared to countries of an equivalent size in Europe. Whereas for women, the countries that are below us are countries who have a very different economic structure and level of provision of healthcare. So it really is, in some ways, a surprise that we're not doing better compared to, we're only really beating countries like Poland, Estonia, and Slovakia. We really ought to be aiming for mortality rates for women more in amongst our peers. So Duncan mentioned the importance of health inequalities, and my next few slides are going to look at that in a little bit more detail. There is, of course, an enormous amount in our second report on health equity, but this is just some highlight figures. The first slide shows inequalities in life expectancy and healthy life expectancy, using deciles of deprivation. So these are groups of people according to where they live, groups according to the levels of deprivation in those areas. And we can see a gradient across all 10 deciles for mortality and for healthy life expectancy. There is a difference at every level. This is something that affects the whole population. It's not just a problem of extremes. If we look again on the next slide at the comparison between the least deprived and the most deprived, we can see that there is, as Duncan mentioned, a 9-year gap in life expectancy for men and a 7-year gap in life expectancy for women. And when we look at healthy life expectancy, the gap is greater. So it's 19 years for men and 20 years for women. Worth pointing out that for both men and women, almost half the population live in areas where healthy life expectancy is slightly less than the current state pension age, so that it's a slightly larger proportion of women than men. So that a significant proportion of our population cannot expect to live to their pension age in good health. Looking at trends in health inequalities, we use a particular measure called the slope index of inequality, which has only been available for a relatively short time, but nevertheless in that period there has been no change in the levels of inequality. And in fact we know from other studies and other data sources there's been little change in health inequality over the period of the last 15 years or so. There is some debate about it, but the message is fairly clear. If we turn then to the causes of inequality, we have looked in the report at risks. I've mentioned some of these risks before. These are behavioural or metabolic. And these are socially patterned, but the level of, the extent of social patterning varies with different risk factors. So we can see here rates of smoking in least deprived and most deprived areas, and there is quite a strong difference for smoking. There's a substantial difference for levels of physical activity, but there's a rather smaller difference for diet, numbers of people who eat, the numbers are numbers of people who don't eat enough fruit and vegetables. But for excess weight, the difference is really quite a lot less. So social patterning is there, but it is different for different risk factors. Duncan also mentioned the importance of looking beyond what we call the proximal risk factors to the underlying causes of ill health. And in many ways, this is one of the strong messages we would like people to take from our report, that in order to understand what is happening in our society in terms of health, we have to look beyond the health sector to the social determinants of health and ill health. And these have been well described, for example, in Michael Marmot's report, and we do have data on them, and we have presented as much as we can in our report. These are just a few examples of the sorts of things that we have reported. We've picked 3 indicators here. The first looks at numbers of young people not in education, employment or training. And we can see that although these figures have improved over time, which is good for the general health of the country, there are still profound differences. So in the most deprived areas, the proportion is 5%, whereas in the least deprived, it's just 3%. Unemployment has also been falling in England. It's now 5.1% in 2015 for the country as a whole. But in the more deprived areas, it's 8.4%, and in the least deprived areas, it's 3.4%. And as Duncan has mentioned, things like employment are enormously important in drivers of health. Looking again at economic factors, one measure is number of households living in fuel poverty. And again, we find differences here between the most deprived and least deprived areas, 12.6% versus 7.6%. And there are a number of other ways in which one can look at these social determinants of health, but it's clear that these are the drivers of the inequalities that we see in the headline health indicators. We also, in our report, wanted to look at hazards to health. I've talked mainly about more traditional measures of health, but there are some important potential threats to health that come from infectious diseases, but also other external hazards, such as flooding, poor and bad weather. One of those threats to health is the emergence of antibiotic-resistant organisms of different forms, and we have presented some data on those. Levels of antibiotics prescribed are an important driver of antibiotic resistance. A great deal of work is being done to try and control the use of antibiotics. And the slide just shows that two messages from this slide. Firstly, that most antibiotics are prescribed in general practice. The numbers are really much greater than those prescribed elsewhere. And that in the recent years, there has been a small decline in antibiotic prescribing. We also talk about the potential emergence of other new infectious diseases and the importance of being vigilant and not being complacent about the huge improvements that have happened in other infections. Clearly, there have been reminders recently about things like Ebola, but we also have to be aware of the ongoing threat from, for example, pandemic flu. So that's the end of our slides, just giving you a taster of the data. I would encourage you to have a look at the reports online. There is a great deal more to see in the reports. We present them on our website. There's a reference here, but you will find them, I hope, relatively easily from our website. They should be seen alongside many of our other data sets and tools, which largely focus on the local population, local factors. One of the things that we have done this time is to produce the report entirely as a digital format, so it's an HTML, it's not a PDF, it's entirely searchable. We hope this will make it more accessible, certainly makes it more flexible. There are lots of links in there to other material, and there's the potential to syndicate the data. We're in general making our data sets more accessible by building APIs into some of the, where it's possible, so that people can use the data as much as possible. We hope that by drawing the data together, we will provide a common understanding of what these data show, which will maximize the potential for people to engage in debate about these important themes based on a common understanding of what the data really show. We welcome feedback. We're looking forward to your questions, but do feedback. I'd also like to thank at this point Justine Fitzpatrick and our team in Epidemiology and Surveillance who produced the reports, our digital team, and everybody else at PHE who's helped produce the work. And thank you very much for coming today, and thank you for listening.
Thank you.
Okay.
I think
that's for the lecture, and I think we're okay here.
So I'm going to field the questions. So I think we just need to wait for a microphone so that this can be caught on stream. If you just say who you are. Okay.
Hi, Ben Spencer from the Daily Mail.
Hi.
There's a lot in there about back pain and neck pain. What's the main driver of that as a cause of ill health? Is this sedentary lifestyle? Is it the fact we're all sitting behind a desk looking at a computer? What's the main thing there?
Great question.
BMI?
Yeah. That's a very good question. We know the prominent risk factors for those two conditions are overweight and low physical activity. So quantitatively, those are the two things that make the biggest difference.
Thank you. The lady in the blue top.
Hello, my name's Ros Godson from Unite the Union. I was interested in you said about days off work, and I wonder whether you could correlate that back to days off school, because do children fully attend school and then suddenly fail to attend work for health reasons, or has this started much earlier on in their life, in which case it brings me to school nurses, and using them much better, more effectively as a sort of well-child occupational health type of service?
Well, very interesting. Would you do the first part and I'll do the...
Yes, gosh, I mean, that's a tremendous question because it covers such a large range of the important topics in public health. The first one might be the life course, the fact that patterns of health start at a very young age, surprisingly young age, and they do carry on into later life, exactly as you say. We have relatively little information on causes of children being off school. So I don't think I'm able to answer as to the individual causes, except to say that, of course, one of the causes of children not attending school is ill health in the parents. So I'm sure it does have an effect. But I don't think we have data on the individual causes of children being off school. And in general, we would like more information on the health of children than we have at the moment.
We are hugely aware of the importance of the very beginning of life and the importance of the 5 universal checks that we want every child everywhere to have, and the measure that then matters the most about the rest of life schooling and the rest of life is, are you ready to learn when you start school at age 5? And our data shows that there's a huge variation in that as well. When you then get to age 11 and you look at reading ability at Key Stage 2, if you have that ability, you're going to do quite well at GCSE at age 16. But if you don't, it drops down to 10%. So we know at age 5 and at age 11 really what's going to happen to that individual. At a population level, there are always, of course, fabulous parents and wonderful schools and that buck that trend, but in the main, we'll know at age 5 what the likely life chances of that child is going to be. And your point about school nursing and the importance of school nursing in that's the context for why school nursing and local government now have the duty from 0 to 19 for all out of hospital childhood care. They're being asked to bring everything to bear to help children first at the very beginning of life, but then as they begin school and as they go forward in their school life. School nursing is an essential part of that. We're happy to talk at another time about school nursing if that was helpful. Thank you. I think gentleman at the front, and then I'll come. Thank you.
Thanks, Duncan and John. Great report. Brent McInerney, I just volunteer in the local community in Gloucestershire, really. I think there's huge opportunities with this report, provided we actually link it over to the evidence around community engagement as well. One of the things I think is really good about this is it brings it all together in one report, so you don't have to look alongside. The question or the point I'd like to raise really is those opportunities to recognise the great assets. We've talked about deprived communities. I think it should be about communities of greater need really. But I do think that there is an opportunity with this, the community engagement work, and actually recognising that there's some fantastic assets in the community will actually help you to deliver it rather than actually you deliver it to them.
Yeah.
Thank you, Ben.
Should I comment on that? Yes, so I think that's absolutely right. Sometimes the language is a bit pejorative. We talk about deprived communities, whereas actually they're challenged communities, or you can use different words. And we completely agree that I hope there's a very strong message in the report that the determinants of health lie outside the health system in many cases, but so do also the tools to address these problems. And we should look to individual places and strong communities to build their own resilience in order to address them. But of course, there are important roles nationally as well. So it's a combined effort that's required.
Is it you or me that is making this noise? I'm keeping my arms. So one of us. Gentleman just in the second row. Thank you.
David.
And David.
It's not me, Duncan. Graham Phillips, I'm a community pharmacist, but I would much rather spend my time helping people lead healthy lives than doling out tablets. So, gentleman mentioned assets in the community. I think community pharmacy is a great asset. As Duncan knows, I think, I'm fascinated with the blue zones, which are 5 areas of the world where men and women live at much higher levels into the age of 100 plus. Most of the Western diseases don't exist. Men and women live equal length lives. Interesting, there's a blue zone in America. Although America has appallingly bad health overall, there is a blue zone in America. Turning to our own country, there are plenty of people who live into their 90s in remarkably good health and very few years of poor health. Do we have our own blue zones? What are we trying to learn within our own country for people who do live into old age with very high quality life?
Yes, you're absolutely right that the consequence of the inequality we see is that we do have populations in the UK, in England in particular, who are healthier than anywhere else, certainly in Europe, possibly in the world. Unfortunately, it seems to be driven largely by socioeconomic factors. So our wealthier populations are the healthiest populations at that level. What we haven't done is look at individuals to see why individuals live longer. And that can be a little bit misleading. And in many ways, what we're trying to do is to improve the general health of populations. So I think, although it's interesting to look at these unusual groups and the very long life, the main objective is to, as Duncan mentioned earlier, is to get most people living longer in a healthier life, not necessarily to reach these high points of longevity. But I mean, I think you're right that we should take comfort from the fact that we are achieving, with our current health system and all the various constraints that we might have, we are achieving very, very good levels of health in some parts of the country.
I'm just conscious there's a lot of questions, so I think David.
Thank you very much. David Butt from the King's Fund. First off, congratulations. It's great to have this all in one place. Well done, Justine and team. It saves a lot of us a lot of problems.
Thank you.
Repeating it, so great stuff. I guess two quick questions. One, I guess, is are you planning to update this on an annual basis? It'd be good to hear your plans for that. It's three, actually. Secondly, I'd love a PDF. I'm a bit old-fashioned, so if it's PDF and HTML, that'd be even better. Some of us do like to print it off and look at the whole thing in the round. But thirdly, I guess the other document you had was around inequalities and equity, and I know you talked a little bit about that. But the focus on ethnicity, and I guess you haven't said anything about ethnicity, so it'd be great just to get a very high-level take from you around where we are on ethnicity and health.
Yep. So quickly, yes, the beauty of the digital format is that we can update different data sources different times, so yes. And we very much welcome your feedback on outputs, so the flexibility of producing different outputs. PDFs are a problem because you can't search. They're blind to search engines once you produce them. So we couldn't produce PDFs from this, but we don't want it to be a PDF document. Ethnicity, there's a lot in there. There are well-known differences in ethnicity. Some of those relate to deprivation. So we also show that your ethnicity to some extent determines whether your level of deprivation, and so those two factors are driving ill health. We have got data, for example, on infant mortality and on other aspects, which I think are fairly well-known differences between ethnic groups. Of course, it's worth pointing out that as our population develops and matures, individual ethnic groups become much more difficult to define. I mean, many of us are of more than one ethnic group these days, so it's perhaps old speak.
Well, I'm from Scotland. David, there's masses of data in here. All we've done is pull out a few aspects, but we are really, really keen to keep building this. So there's what we're calling an index document that can serve many needs. So folk will look at this and say, but you haven't covered this, or have you thought about that? And we'll be very active in responding to that. Gentleman at the front. And yes, thank you.
I'm Ian Wiley, I'm Chief Executive of the Royal College of Obstetricians and Gynecologists. Firstly, thank you very much for this work. It's enormously valuable for places like mine. I was struck by the apparent paradox, John, in the fact that women's indicators are all better than men, but then that quite shocking slide that you showed where women, compared to other European countries, really are just above very profoundly different economic environments. And I just wonder whether you've got any thoughts about that, or whether you're planning to do any further work, because there seems to me to be an inequality there between men and women in the reverse of what we usually find.
I think that's true. You have to look at actual numbers are life expectancy for women in this country is very good, even by international standards. So we're looking at relatively small differences. But you're right, I mean, and it does focus on cancer. So again, we could refer you to the work that we're doing on early diagnosis of cancer as one of the main things that needs to be done.
Thank you. Gentleman just over here on the left, and then I'll move to the centre. Thank you.
Thank you. I'm Ed Humferson from the UK Statistics Authority. I'm usually described publicly as the statistics watchdog. And in that capacity, well done. This is exactly the sort of thing that I've been banging on about tediously, needing to be produced, really cohesive, coherent overviews. So that's great. My question is about something that you touched on, Duncan. You mentioned the importance of work. Yes. And the relationship between work and good health outcomes. My question is that true in all circumstances for all types of work, or are there some types of work which are less good for you? And I'm particularly thinking, of course, about the contemporary debate about unstable work, 0 hours work, the gig economy. Do you have any evidence on that?
So, can I ground it almost in a mental health context of the importance of having a reason for getting up in the day and having something meaningful to do in the day. Enough money to live on, of course, is a hugely important part of our message that income and outcome are highly related. It's less to do with north, south, urban and rural, and to do with income, if I use that rather than deprivation. And the point about the north is it's just more intense in the north, if you like, about the income levels. So, of course, having a reason for being up in the day is a massively important part of your health and well-being and being in contact with people and so on. So it doesn't have to be about paid work. It is about, it could be, and it's a hugely important part of contributing, the point at the beginning about community assets, in volunteering. And certainly for some people, not just young people, volunteering is a really effective way of getting into long-term paid work. Now, there are, of course, differences in the sorts of work and how that affects your health. And, we've known this forever about the difference between manual and, and the gentleman from the Daily Mail was talking about back pain and joint pain and sedentary. Like, we talked about overweight and so on. But, of course, the sort of work that you do will also affect those sorts of risk factors. So what we're saying is that having a reason for being up and having something meaningful to do, a reason for getting out and meeting people is massively important. We're also saying that having a decent income is probably the most important factor affecting. And if we took all the factors affecting, that would be the most important in closing that health gap. If you know very well how multifactorial all this is, and we're not, well, Professor Newton talks of the data, I listen and say, oh, that means X. And to me, it's income, and it's about having a reason for being up in the day, it's having a job. Speak directly to your question, we want people to get increasingly good work, and work where they feel confident, where they've got influence over that, they feel empowered, inspired, all the things that we know people most want from working life. But it covers that whole spectrum for just having a reason for being up in the day, something meaningful to do through to increasingly good work. Having a job, a reason for being up in the day is good for your health. A human right is to have something to complain about. I travel by Southern Rail. People complain about the weather. It's really important to have something, to have connectedness in your life.
Just one comment on work. Health is an input to the economy as well as an output from work. So a healthier workforce makes a big difference to the economy. So it's a two-way relationship with work.
Of course, that's such an important. Right, this is an economic question for the country. Mortality, being dead early before your time, is not a productive contribution. Being ill for a very long time reduces your productive contribution and to the wealth, economic development of this country. You can look at this as an individual, a population, as a moral question, but you can also, and very definitely, consider this an economic question about what the country is not enjoying as a consequence of this burden of ill health. I know there are masses of questions. This gentleman in the red tie and then the lady just along from him. Thank you.
Thanks, Henry Bodkin from The Telegraph. Could you just talk a bit more about that stat you mentioned about nearly half of people not getting to the state pension age in good health?
Yes.
Were you surprised by that? Sounds quite depressing. Is there anything to compare that to? Has that got worse over time?
The short answer is it hasn't got worse over time. I mean, the positive message is that as we're getting older, the proportion of our lives that we are spending on average in poor health is the same. It's just that as we're getting older, that length of life in poor health is also longer. It's also worth pointing out that the question on poor health is a evaluative question, so it depends on people's expectations. So it's the response to the question is, do you enjoy good health? And that depends on what people's expectations are. So it's possible that people's expectations have become higher, but we don't know. So it's an important statistic. I think it's a salutary lesson.
Yes.
But the short answer is no. There's no big change. But it does have implications clearly for our policy on work and how long we should expect people to carry on working.
Could you just elaborate a bit on that? Do you think the state pension age should be lowered again?
Well, we don't talk about that in the report. Our task is to present these data for policymakers so that exactly that sort of debate can be based on the best possible data.
Thank you. Lady Furlong, thank you, just down here. Just in the, yes, thank you.
You touched on the threat of a flu pandemic.
Yes.
Is that one of the biggest health threats facing us, or is that likely to be something else?
Okay. Yeah.
Well, the flu pandemic is, by its nature, very difficult to predict. Our current best estimate is that the chance of a flu pandemic each year is 3%. However, there's a wide range around that estimate. A flu pandemic, if it is on the scale of the pandemics that we've had before, such as 1918, would be devastating, and that's why it features so high. But clearly this is something that we have a lot of preparation for, and so we're actively prepared and planned for a flu pandemic. We had a minor, a flu pandemic in 2009, which was significant, but nothing like as severe as some of the others. And we think in a modern context that the flu pandemic would be more similar to the 2009 than to the 1918. So it's important, but it's not something that we should be worrying about on a daily basis. But it's important that it is planned for.
We worry about it on a daily basis. The public doesn't have to. Can I bring to the lady at the back? Thank you.
Hi, Jenny Edwards. I'm Chief Executive of the Mental Health Foundation. I was struck, John, by your comment that musculoskeletal and mental health dominate in the causes of poor health. Given that, and also Professor Marmot recently described mental health as the gateway to all other health inequalities, I was wondering what the social gradient looks like on mental health issues compared to other health issues. I look forward to reading the full health equity report, which will give me some of that.
Yes. Well, mental health is one of those areas where we really need much better data, as you will know very well. So I don't think I can comment on the mental health gradient because we simply don't have reliable enough data. Clearly, there is a gradient for all the reasons that you might expect, but we don't really have. We can't produce the nice slides that we can for mortality for mental health that we can for these other causes. And that's also true for musculoskeletal conditions. So one of the messages from this report is we need to focus a bit more on these causes of ill health and get better data to answer those questions.
Thank you. I am the gentleman right at the back and then the gentleman in the check shop.
I'm Paul Litchfield, What Works Centre for Wellbeing. I was surprised at the level of sense organ diseases in men over 50.
Yeah.
And I wonder if you have any insight into how much of that might be occupational, because work is critical for health, but it has to be good work.
Yeah.
And if occupational causes are a material factor, then clearly it needs to feed into priorities for colleagues in HSE and elsewhere.
Yes. I think I'll have to refer you to the report, though. I haven't got the figures in my mind, but it's a very important problem, and I think it is surprising. As I say, I know I have reported on this before in a piece I wrote, looking back at it now 20 years ago, that we need to address the causes of loss of independence and particularly bearing in mind Bren's point about assets, that people need to be given the tools to look after themselves and to look after each other. And sense organ problems are a major cause of loss of independence, loss of capability, capacity, which is largely, I think, unrecognised. So I hope we've done something to raise the profile of that, but clearly we need to do more.
Thank you. Gentlemen, there at the back.
So thanks very much. I'm Mike Napton from the British Heart Foundation. So fantastic report and very gratifying to see the trend with heart disease. But of course the data is historical, and it seems to me that data is only useful if it informs what we do going forward. And there are obviously lots of recommendations that can fall out from this. But there are two questions that I came to mind. One, do you have any sense of the trends going forward rather than looking back? So for instance, given the emphasis on economic drivers in a period of austerity, is that going to make our public health better or worse? And then a specific question, if I may, you didn't mention air pollution as a driver for ill health, and from a cardiovascular point of view, it does seem to be a significant problem in terms of cardiovascular disease, and that affects the poor more than the wealthy.
Yes. So yes, future predictions, we are actively working on that, working with partners on various models. Models are useful to illustrate what's going to happen in the future, but they can never tell you definitively what's going to happen in the future. I'm a strong believer in Hume's problem, but people who don't know have to look it up. I haven't got time to explain it. But we essentially don't really know that future futures are going to be like past futures. But nevertheless, we can predict things fairly in the near future. And we know that a lot of the problems which are currently pressing now are just going to get worse if we don't do something about them. Air pollution, yes, very important. Where Public Health England is very actively looking at that. We need to, again, generate more precise evidence. It does feature in the report, but because it affects everybody, admittedly, as you say, socially patterned to an extent, but it does affect almost all of us, and therefore the effect is more difficult to perceive. If everybody smoked, it would be quite difficult to show that smoking caused lung cancer.
So we regard air pollution where tobacco was maybe 30, 40 years ago in our understanding of the science, but even more so about the interventions, or the importance of the interventions that we can make, stratified by impact on health and cost, and providing the evidence in support of, if you do this, you can expect that. Less concerned about, is it 30,000, 35,000 or 25,000, and more, what practically can you do about this? So it is referred to in this index report, but there's other work that we can talk with you further about on this. Gentleman right at the very back in the red tie. Yes.
Martin Todd, Chief Executive of the Men's Health Forum. First of all, thank you very much indeed for having such a lot of great gendered data in here and looking at gender so much. I was surprised to see that skin disease was the second greatest burden of morbidity for men. I just wondered if you could say a bit more about that.
Yes, I think people do ask. It's because skin disease is so common. It's particularly a problem in younger age groups. It's proportionately a big problem. I am actually a dermatologist by clinical background, and I did studies on the quality of life impact of dermatological conditions, and it's profound. and often, I think, less well understood, a little bit like sense organ diseases. So yes, it's not a surprise to me that skin diseases feature prominently in this report. It's eczema, psoriasis, and acne. Those are the big common ones.
Thank you. Yes, right at the back, and I think there's only time for just one more question.
Thank you. Christine Hancock, C3 Collaborating for Health. We very much focus on the risk factors that are so clearly spelt out in your report. And I think others have touched on sort of what next. But I'm particularly interested in the physical activity issues that you highlight. Seems to me that as a country, we're almost obsessed with the food issue. And physical activity has such benefits, and we don't highlight it or action it in quite the same way. And I wondered what your thoughts were. Thank you. But thank you for the report.
Yeah. So yes, we have been active on physical activity. Again, this is a really good example of where the answers lie well outside the healthcare system. So it's a question of getting the message out more broadly. For example, we've recently produced some planning guidance on spatial planning for local authorities to promote opportunities for physical activity, active transport, access to green space. There's clearly something about education and schools, but also workplaces. It's a very wide-reaching problem. One element of it is provision of the infrastructure, but another element is the behaviour change, the encouragement for people to use the infrastructure. And all of these things need attention. But yes, you're quite right to highlight it.
We were particularly pleased with the sugar levy. It's a very smart bit of legislation encouraging manufacturers to help parents, particularly by taking the sugar out, but that the benefit of that levy is going to go into schools to help schools get the children moving more. It's just an example of how you influence in a way because of the importance of what you're saying. I know there have been so many questions. I don't know that I've done that well in gathering them in a particularly good order. I have tried. There's only one question that we can take before we lose our... I'm getting a vote for... Are you suggesting the gentleman with the red...
I am suggesting. I have a question, but I'll give it to
you. That's very kind of you. Thank you.
Thank you very much. Samir Jaraj from the Race Equality Foundation, and I just want to commend you on the focus on ethnicity. One of the things raised in here is the lack of data on Gypsy, Roma and Traveller communities. So whilst there are 18 indicators in here, there's only one for which we have data for those communities, despite the fact that they have the lowest life expectancy of any ethnic group in the UK. So I was wondering if you could talk a little bit about how you are going to address that data issue.
A general comment is that you're absolutely right, and in fact there are a number of dimensions of equality for which we have almost no data. So clearly one of the important messages here is that if we are serious about addressing a whole range of different inequalities, we need to try and collect the data more accurately. I haven't got any specific... I can't answer that specifically, but we might be able to look into it and give you an answer later. By their nature, that particular community is difficult to study. So I think what we're looking at is probably bespoke research studies rather than routine data. But the fact that it's challenging to collect the data is not an excuse for not having it.
Could I... we're going to close just now, but this is really just to get it out to you guys and for those that are watching down the line. As I say, there's masses in here. What we think is different and hopefully helpful is it's in a single place and you can interrogate it. And we are very, very keen that you can help us improve it by asking us questions and perhaps directing us to areas we haven't thought about. But in the main, we want to shift the conversation from health being regarded as a matter only for the health service, something we should all be very proud of, but it's not sufficient. It's never going to be enough to improve the health of the people, and it certainly won't be enough to close the gap between those who have good health and those that don't. And the factors that we have set out here today we would regard as this having been a very important moment if in 2 to 3 years' time everyone was talking about the importance of having work, the importance of having a decent income, because it's a health issue. It's about how we improve the health and well-being and wealth of this country. Thank you very much. Thank you, John. Thank you. Thank you. Thank you.